So we are now going to start the second video for part 2 of chapter 10. And this is exciting because we get into coronary artery disease. Coronary artery disease, huge cause of morbidity and mortality across the world, but especially in the United States. It's a major factor limiting the cardiac oxygen supply because there's presence of the atherosclerotic plaque. And coronary artery disease means that the cardiac oxygen demand is not going to be met by the oxygen supply. And that often causes big problems such as ischemia and infarction. Angina can be the early symptom of myocardial ischemia, but it's not always experienced by those with significant narrowing of large or medium-sized coronary vessels. Women are more likely to have disease of our medium-sized vessels and may have atypical symptoms. Okay. Before we get into this and how the book talks about coronary arteries and coronary artery disease, let's jump over to our osmosis.
Our hearts are responsible for sending blood throughout our body and bringing it back to our lungs in a constant exchange of oxygenated and deoxygenated blood. Here at Osmosis, we also think your hearts are responsible for starting with the heart and showing us love every time you watch one of our videos. But remember, the heart itself also needs its own blood supply, called the coronary circulation, which it gets from the right and left coronary arteries. The coronary arteries are embedded in fat and course across the surface of the heart just deep to the epicardium. Let's begin with the right coronary artery, or RCA, which has its origin in the right aortic sinus and passes to the right side of the pulmonary trunk. Close to its origin, the RCA gives a sinoatrial nodal branch, which supplies the sinoatrial node. The RCA then descends in the coronary sulcus. Along the way, it gives off the right marginal branch, which gets close to the apex but doesn't reach it and supplies the right border of the heart. After giving this branch, the RCA turns to the left and continues its journey in the coronary sulcus posteriorly. Here, the RCA gives yet another branch, the atrioventricular nodal branch, which supplies the AV node. The RCA usually gives the posterior interventricular branch, which descends in the posterior interventricular groove. This branch supplies areas of both ventricles and sends perforating interventricular septal branches into the IV septum. Finally, the terminal branch of the RCA continues for a short distance in the coronary sulcus. The left coronary artery, or LCA, originates from the left aortic sinus and passes between the left auricle and the left side of the pulmonary trunk and gets in the coronary sulcus. At the superior end of the anterior interventricular or IV groove, the LCA divides into two branches, the anterior interventricular or IV branch, sometimes called the left anterior descending or LAD, and the circumflex branch. The anterior IV branch passes through the anterior IV groove to the apex, where it turns around the inferior border of the heart and typically anastomoses with the posterior IV branch of the RCA. The anterior IV branch supplies parts of both ventricles and the anterior 2/3 of the interventricular septum through septal branches. In many people, this branch gives rise to the lateral branch or diagonal artery, which descends to the anterior surface of the heart. Now, the circumflex artery runs in the coronary sulcus around the left border of the heart towards the posterior surface of the heart. On its way, it gives the left marginal branch, which also has many tiny branches that supply the left ventricle. Most commonly, the circumflex branch of the LCA terminates in the coronary sulcus on the posterior aspect of the heart prior to the crux of the heart. Okay, to wrap things up, RCA supplies the diaphragmatic surface of the heart, the right atrium, most of the right ventricle, the diaphragmatic part of the left ventricle, and it usually also supplies the posterior third of the interventricular septum, the sinoatrial node, and the AV node. The LCA typically supplies the left atrium, most of the left ventricle, part of the right ventricle, the anterior 2/3 of the IVS, including the AV bundle, through perforating IV septal branches and the sinoatrial node in some people. And the reason for all the sums and usuallys is because there is something called dominance of the coronary arterial system, which refers to whether the right or left coronary artery gives off the posterior interventricular branch. In 67 to 85% of people, the right coronary artery gives rise to the posterior interventricular branch, so the most common distribution is the right dominant pattern. In this case, the RCA and LCA are each in charge of about 50% of the heart supply. In about 8 to 15% of cases, LCA is dominant and the posterior IV branch comes from the circumflex artery. In 7 to 18% of people, there is codominance, and both RCA and LCA give rise to branches that run in or near the posterior IV groove. And if you thought that all on its own made each of us special, think that some people might have just one coronary artery. In others, the circumflex artery might have its origin in the right aortic sinus. 4% of people have an accessory coronary artery. Finally, the RCA gives the sinoatrial nodal branch 60% of the time and the AV branch 80% of the time, while LCA is responsible for the other scenarios. That's quite some variation. Even though the branches of the coronary arteries are considered to be functional end arteries, the heart does have the potential to develop collateral circulation. This typically occurs between the termination of the right and left coronary arteries in the coronary sulcus between the IV branches near the apex in 10% of normal hearts and can potentially develop for all hearts. Alright, now where there are arteries, there are veins. So there are heart veins that empty into the coronary sinus, which drains into the right atrium, and some small veins that empty directly into the right atrium. On a posterior view, you can see the main vein of the heart is the coronary sinus, which is a wide vein that runs from left to right in the posterior part of the coronary sulcus. On its left side, on the anterior surface, it receives the great cardiac vein, which is the main tributary of the coronary sinus and drains the areas supplied by the LCA. The great cardiac vein begins as the anterior interventricular vein near the apex of the heart, which accompanies the anterior IV branch of the LCA towards the coronary sulcus. Then it turns left, and this second part of the great cardiac vein runs around the left side of the heart with the circumflex branch of LCA to reach the coronary sinus. Then there's the oblique vein of the left atrium, also called the vein of Marshall, sadly not named after the lovable character from How I Met Your Mother, which is a small vein that descends over the posterior wall of the left atrium and merges with the great cardiac vein to form the coronary sinus. Let's switch gears and look at some more veins on a posterior view of the heart. Here, the coronary sinus receives the middle cardiac vein, which accompanies the posterior interventricular branch, and the small cardiac vein, which accompanies the right marginal artery of RCA. These two veins drain most of the areas supplied by RCA. The left posterior ventricular vein and the left marginal vein also open in the coronary sinus. Some other veins begin over the anterior surface of the right ventricle, cross over the coronary sulcus, and end directly in the right atrium, or sometimes enter the small cardiac vein. Alright, as a quick recap, the heart receives arterial blood supply from the right and left coronary arteries and their branches, and venous blood is drained by the middle cardiac vein, the left marginal vein, as well as the left posterior ventricular vein, part of the small cardiac vein, and the oblique vein of the left atrium. Dominance of the heart refers to whether the right or left coronary artery gives off the posterior interventricular branch, where 67 to 85% of people are right coronary artery dominant. On an anterior view, you can see some of the vessels that supply the heart, such as the RCA and its right marginal branch, a bit of the LCA and the whole anterior interventricular branch of LCA, as well as part of the circumflex artery. You can also see the small cardiac vein following the right marginal branch, the anterior part of the great cardiac vein following the anterior interventricular branch, and finally a small part of the middle cardiac vein. On a posterior view, you can see the left posterior ventricular vein, the posterior interventricular artery, the middle cardiac vein, and the coronary sinus, which collect most of the venous drainage.
So that was a great description for us of the coronary arteries and the coronary veins. Okay, before we jump into coronary artery disease and talking about the angina and those things, and then it leads us into the ST elevation for STEMIs and non-STEMIs, and we're going to get into all of that. We do get into what we're talking about with part of the microvascular system of the coronary arteries, and some of those things. So I'm going to play a different video that we've not watched yet that is arterial disease. So it does encompass part of the chapter 9 and part of us into chapter 10. It does give us a great, though, review on atherosclerosis to understand its formation. So I'm tying this back in together, so it's all going to make hopefully more sense to us. It's a good review again, even though we learned it in chapter 9. Let's learn it better here in chapter 10, so that when we understand the treatment of heart disease and coronary artery disease, it's really honed in and we can understand why we need to worry about our LDLs and XYZ.
Words look the same. Arteriosclerosis, atherosclerosis, and arteriolosclerosis. Arteriosclerosis is a general umbrella term describing diseases where the wall of the artery becomes thicker, harder, and less elastic than normal. You can figure that out right from the name, arterio, which is Greek for artery, and sclerosis, which is Greek for hardening. Now, the word arteriolosclerosis is any sort of hardening of small arteries and arterioles. This is also pretty easy to remember since the olo in the middle of the word indicates small arterioles. And then finally, atherosclerosis is the hardening of any artery, even though it's usually medium to large-sized arteries, which is caused by the buildup of plaque. These plaques are called atheromatous plaques and happen in the innermost wall of the blood vessel, called the tunica intima, or endothelium. Okay, now that we've differentiated between all three of these words, let's first take a look at atherosclerosis. So the blood vessel endothelium is made up of a single layer of cells and does two jobs. First, it protects the rest of the blood vessel wall from the blood, like a coat of varnish on your wood furniture. And then secondly, it secretes proteins on its surface to prevent the blood from clotting, because blood just inherently likes to clot whenever it gets the chance. Now, your endothelium can become damaged in a lot of ways. Low-density lipoproteins, chemicals from smoking cigarettes, and high blood pressure all wreak havoc on the endothelium, because these irritants break down the endothelium. The damaged endothelium allow low-density lipoproteins to enter the endothelial wall. White blood cells, called monocytes, follow the low-density lipoproteins and break them down through oxidation. Okay, so you might think that macrophages eating the embedded low-density lipoproteins is a good thing. But if there are a lot of low-density lipoproteins, then the macrophage will eat so much cholesterol that it can die. It basically eats itself to death. After it dies, it deposits itself under the damaged endothelium. So now we have a dead macrophage filled with low-density lipoproteins stuck in the damaged endothelium as well. These dead macrophages are called foam cells, and that's because some guy a while back looked at these things in a microscope and thought they looked like foam on the beach, hence the name. Also, when the macrophage dies, it releases cytokines, which calls over more monocytes which come over and eat more low-density lipoprotein, inevitably dying while doing so. And thus this vicious cycle of gross overeating and massive fatalities has begun. As more and more of these foam cells build up, they form a lesion we call a fatty streak. Now the fatty streak is thrombogenic, meaning that blood can clot on it. Platelets begin to gather at the damaged endothelium and release platelet-derived growth factor, which in turn encourages the growth of smooth muscle cells. Now normally smooth muscle cells are supposed to stay within the middle layer of the blood vessel, the tunica media. The release of platelet-derived growth factor draws the media smooth muscle cells to the tunica intima, where they multiply. The growing smooth muscle secretes collagen, proteoglycans, and elastin fibrous cells that help form a wall around the fatty streak, preventing blood clotting. And we call this extracellular matrix wall a fibrous cap, and together both the fatty streak and the surrounding fibrous cap is called plaque. The presence of fatty streaks cause the underlying smooth muscle in the blood vessel wall to also start depositing calcium into the plaque, creating crystals. Normally, calcium is deposited into the vessel wall by low-density lipoproteins and is then removed by high-density lipoproteins. The accumulation of plaque in the vessel messes up with the ability of the high-density lipoproteins to remove calcium from the vessel, so a buildup of calcium occurs in the vessel wall and it crystallizes. Now remember, calcium makes stuff hard, which is why your bones are full of calcium, right? So this deposit of calcium into the plaque is what stiffens the walls of the arteries. Now remember the word that describes the immune system getting involved with something is called inflammation. So atherosclerosis is an inflammatory disease. Now, as an aside, the protein called C-reactive protein increases in the blood during an infection or when inflammation is occurring somewhere in the body. While an elevated C-reactive protein isn't specific enough to diagnose atherosclerosis, it can act as like a red flag that atherosclerosis might be occurring, especially if someone has atherosclerosis symptoms or other risk factors. From time to time, that fibrous cap can crack and expose the underlying thrombogenic foam cells to blood. And this can happen randomly, and when it does, within moments you can see a blood clot start to form within the already partially occluded artery, quickly leading to even less blood being able to flow by. After about 70% of the blood vessels occluded from the plaque and the new overlying blood clot, cell injury and death begin in the areas that were relying on that blood flow. If blood flow is reduced in the coronary arteries, angina and myocardial infarctions can occur. Seriously occluded internal carotid and middle cerebral arteries lead to strokes and cerebral atrophy. An occluded superior mesenteric artery affects the small intestine, and an occluded popliteal artery can cause peripheral vascular ischemia like gangrene or claudication, which is frequent leg cramping during exercise. Now, the building up of plaque also weakens the artery walls, which means it can lead to aneurysms, which explains why atherosclerosis is a main cause of abdominal aortic aneurysms. But the complications of atherosclerosis don't stop there. If we move on to the kidneys, plaque buildup in the renal arteries reduces blood flow to the kidney and tricks the kidney into thinking blood pressure is low. The kidneys then activate the renin-angiotensin-aldosterone system, which unnecessarily increases blood volume in the body, causing hypertension. Occasionally, some of the plaque can also break off from the main plaque deposit and become an embolism, floating around in the bloodstream until it gets stuck in a smaller blood vessel or another artery with significant atherosclerotic plaque buildup. And you can totally see this in a tissue biopsy, as the affected blood vessel will have cholesterol clefts, these big white entities in the middle of the blood vessel. So, moral of the story, atherosclerosis isn't great. There are a few things that you can do to prevent it, though. Maintaining a normal blood pressure and avoiding excessive sugary and fatty foods and drinks all reduce your risk of the disease. There are other risk factors that may be out of your control, though. You're more likely to get atherosclerosis as you get older. Males and postmenopausal females are also more prone to the disease, but premenopausal females are less at risk because higher levels of estrogen have a protective effect against atherosclerosis. No big surprise here, but people who have a family history with atherosclerosis are also more at risk. Okay, that's enough atherosclerosis for one day. Another type of arterial sclerosis is called Monckeberg sclerosis, or medial calcific sclerosis. And this is caused by the formation of calcium crystals in the muscular layer of the blood vessel wall, leading to hardening of the blood vessel. But this doesn't affect the diameter of the lumen. Since blood flow isn't impaired, it doesn't really cause any signs and symptoms, so it's usually detected during a diagnostic procedure for something else, like mammograms, since mammographies are used to look for calcification as a sign of breast cancer. So the last arterial sclerosis category we'll talk about is arteriolosclerosis. Arteriolosclerosis is a category of blood vessel hardening diseases that affect small blood vessels and is caused by high blood pressure and diabetes. Hyaline arteriolosclerosis is one type of arteriolosclerosis where instead of a buildup of plaque in the walls of the arteries, the high blood pressure blood flowing through the blood vessels causes proteins floating around in the blood to leak into the blood vessel walls. Over time, you'll see these walls begin to build up with a lot of these proteins, making the blood vessels stiffer. When you look at a blood vessel through a microscope, you'll see a pink hyaline material that's making the blood vessel very thick. Thick walls mean that the lumen of the vessels start to get narrower, and this basically reduces blood flow to the organs that are supplied blood through these vessels, and the organs get starved of oxygen. And this is usually seen in the kidneys, where not enough blood is supplying the small glomeruli blood vessels and the glomerulus itself, causing the glomerulus to scar, which is summed up nicely by the term arteriolonephrosclerosis. If we don't do something to stop it, we'll see scarring occur to enough glomeruli that a person develops chronic renal failure. People with diabetes can have hyaline arteriolosclerosis through a different mechanism. Chronic exposure to high blood sugar can directly damage the endothelium, likely by altering carbohydrate and fat metabolism, which in turn damages the basement membrane of the blood vessels. Another type of arteriolosclerosis is called hyperplastic arteriolosclerosis, which also happens due to the thickening of the blood vessel walls, and occurs when a person has extreme hypertension. The blood vessels compensate for this high blood pressure by adding additional layers of smooth muscle and basement membrane to the blood vessel wall, making the blood vessel stronger. The downside of this extra muscle is that it decreases the space in the lumen for blood to pass through. If you look at these hyperplastic blood vessels under a microscope, you can see the rings of smooth muscle with a small lumen, which kind of looks like an onion. Just like in hyaline arteriolosclerosis, hyperplastic arteriolosclerosis can then cause ischemia in the organs it supplies. Also, just like hyaline arteriolosclerosis, hyperplastic arteriolosclerosis typically affects the arterial walls of the kidney. The high blood pressure destroys the blood vessels in the kidneys, causing renal ischemia. What's unique in hyperplastic arteriolosclerosis is that the kidneys themselves will look a bit like they have insect bites everywhere. And that's because the high blood pressure ruptures the weakened renal blood vessel walls, causing small hemorrhages all over the kidneys. These small blood vessel hemorrhages give the kidney tissue the appearance that they've been bitten by insects. Narrowed and hardened arteries don't generally cause symptoms until the blockage is significant. Once that happens, there might be pain distal to the affected artery, including chest pain or angina if it's a coronary artery, or foot and leg pain if the blockage is in an artery in the leg. If the artery goes to the brain, it can cause stroke-like symptoms like confusion or weakness. If the artery goes to the kidneys, it can cause high blood pressure or renal failure. Diagnosis usually starts with a physical examination, which can show a weakened pulse below the blockage or brutes, which is a whooshing sound over the arteries heard through a stethoscope. In addition, an imaging study like an angiogram, where a dye is injected into the blood vessel, can show narrowing of the vessels. These diseases can often be treated with lifestyle changes, like stopping smoking and improving diet and exercise, and that can help improve underlying conditions like diabetes mellitus or hypertension. In some cases, medication might be required. Cholesterol medications like statins can be used to improve lipid profiles. Antiplatelet medications like aspirin can be used to reduce blood clotting, and blood pressure medications like beta blockers, diuretics, and angiotensin-converting enzyme inhibitors, or ACE inhibitors, can help lower blood pressure. With severe atherosclerosis, angioplasty can be used to open a blocked artery with a balloon, followed by the placement of a stent to keep the artery open. A surgery called an end arterectomy, often done with the carotid arteries, can also be done to remove fatty deposits. Finally, a blood vessel can be grafted in and used to bypass or go around a blocked artery. Alright, as a quick recap. Arteriosclerosis literally means hardening of the arteries, and describes diseases where arteries become thicker, harder, and less elastic. Arteriolosclerosis specifically refers to the hardening of the arterioles, which often affects blood flow to the kidneys. And atherosclerosis describes the buildup of atheromatous plaques in medium to large arteries. Thanks for watching.
So we are going to next move on to angina, which starts to give us some of the information, and then we'll move on to a heart attack.
Angina comes from the Latin angere, which means to strangle, and pectoris comes from pectus, meaning chest. So angina pectoris loosely translates to strangling of the chest, which actually makes a lot of sense because angina pectoris is caused by reduced blood flow, which causes ischemia to the heart muscle, or lack of oxygen to the heart, almost like the heart's being strangled, which causes terrible chest pain. Stable angina, or chronic angina, is the most common type of angina, and it usually happens when the patient has greater than or equal to 70% stenosis, meaning 70% of the artery is blocked by plaque buildup. This small opening that blood flows through might be enough to supply the heart during rest, but if the body demands more blood and oxygen, like during exercise or stressful situations, the heart has to work harder, and therefore needs more blood and oxygen itself. It's during these times of exertion or emotional stress that people with stable angina have chest pain, since the blood flow isn't meeting the metabolic demands of the heart muscle, or myocardium. But the pain usually goes away with rest. In the majority of cases, the underlying cause of stable angina is atherosclerosis of one or more of the coronary arteries, the arteries supplying blood to the heart muscles. Other heart conditions that might lead to stable angina are ones that cause a thickened heart muscle wall, which would require more oxygen. This increase in muscle size can be due to hypertrophic cardiomyopathy from a genetic cause, or as a result from the heart having to pump against higher pressures, as is the case in aortic stenosis, which is a narrowing of the aortic valve, or hypertension. These larger, thicker heart muscles require more oxygen, and if the patients can't meet the increasing demands, they feel pain in the form of angina. Whatever the case, the heart needs blood, and if we look at the heart wall, there's 3 layers: the outermost layer, the epicardium, then the myocardium in the middle, and then the endocardium inside the heart. The coronary arteries start up in the epicardium, and then dive down and supply all the heart tissue. If blood flow is reduced or the myocardium is thicker, blood has a harder time reaching the deeper layer just under the endocardium, called the subendocardium. Therefore, the classic finding with angina is subendocardial ischemia, meaning less oxygen is reaching the region just under the endocardium. This ischemia is thought to trigger the release of adenosine, bradykinin, and other molecules that stimulate nerve fibers in the myocardium that result in the sensation of pain. That chest pain is usually described as feeling like pressure or squeezing, and it can radiate to the left arm, jaw, shoulder, and back, and sometimes is accompanied by shortness of breath and diaphoresis, or sweating. Usually the pain and symptoms last less than 10 minutes, generally 2 to 5 minutes, and subside after the exertion or stress is taken away, and therefore the heart muscle isn't demanding as much blood. Now, unlike stable angina, which describes when patients have pain only during periods of exertion or stress, but not during rest, there's also unstable angina, which is when patients have pain during exercise or stress as well as during rest. It never really goes away. Unstable angina is usually caused by rupture of atherosclerotic plaque with thrombosis, meaning a blood clot forms on top of a mound of plaque. Although the occlusion might not block the entire vessel, there's now even less room for blood to flow by, and the heart tissue is starting to feel starved for oxygen even while pumping at a normal rate. Unstable angina, for the same reason as stable angina, involves subendocardial ischemia, and it should be treated as an emergency because patients are at a high risk of progressing to myocardial infarction or heart attack. The key distinction is that unstable angina means that the heart tissue is alive, but ischemic, or starving for oxygen, whereas myocardial infarction means that the areas of the heart tissue have already begun to necrose, or die. Now, a third type of angina is vasospastic angina, also known as Prinzmetal angina, and patients may or may not also have atherosclerosis. Ischemia and resulting chest pain is due to coronary artery vasospasms, meaning the smooth muscles around the arteries constrict extremely tightly and reduce blood flow enough to cause ischemia. Episodes of vasospastic angina don't correlate with exertion and can happen any time, including at rest. The underlying mechanism causing vasospasms isn't well understood, but likely involves vasoconstrictors like platelet thromboxane A2. Unlike both stable and unstable angina, in this case the coronary artery is constricted so severely that all layers of the heart wall being supplied are affected, Therefore, it's referred to as transmural ischemia. Alright, so if we line these three up side to side, there are some important clinical similarities and differences. First, it's super important to remember that in each case, the injury to cardiomyocytes isn't permanent, meaning it's reversible and the cardiomyocytes don't die, which is how this differs from myocardial infarction. On an electrocardiogram, or ECG, both stable and unstable angina show an ST segment depression, since ischemia is limited to the subendocardium. In contrast, vasospastic angina shows ST segment elevation due to transmural ischemia. Rest tends to relieve stable angina, whereas unstable angina and vasospastic angina can happen anytime, including at rest. In terms of medications, all three can be treated with nitroglycerin, which is a vasodilator that increases blood vessel diameter to allow more blood flow. In addition, vasospastic angina also responds to calcium channel blockers. Alright, as a quick recap. Angina pectoris is chest pain caused by reduced blood flow resulting in a lack of oxygen in the heart muscle. There are three types: stable angina, unstable angina, and vasospastic angina. Rest tends to relieve stable angina, but not the other two types, and all three can be treated with nitroglycerin. According to the World Health Organization, cardiovascular disease is the leading cause of death worldwide, as well as in the US. Of those, a large proportion are caused by heart attacks, also known as acute myocardial infarctions or just myocardial infarctions, sometimes just called MIs. The word infarction means that some area of tissue has died due to a lack of blood flow, and therefore a lack of oxygen. Myo refers to the muscle, and cardial refers to the heart tissue. So with a heart attack, or MI, you have death of heart muscle cells because of a lack in blood flow, a process called necrosis. Now, the heart's main job is to pump blood to your body's tissues, right? Well, the heart also needs blood, and so it also pumps blood to itself, using the coronary circulation. The coronary circulation is the system of small arteries and veins that help keep the heart cells supplied with fresh oxygen. Heart attacks happen when these small arteries become blocked and stop supplying blood to the heart tissue. And if this happens for long enough, heart tissue dies. Almost all heart attacks are ultimately a result of endothelial cell dysfunction, which relates to anything that irritates or inflames the slippery inner lining of the artery, the tunica intima. One classic irritant are the toxins found in tobacco, which float around in the blood and damage these cells. That damage then becomes a site for atherosclerosis, a type of coronary artery disease where deposits of fat, cholesterol, proteins, calcium, and white blood cells build up and start to block blood flow to the heart tissue. This mound of stuff has two parts to it: the soft, cheesy textured interior and the hard outer shell, which is called the fibrous cap. Collectively, this whole thing's ominously called plaque. Usually, though, it takes years for plaque to build up, and this slow blockage only partially blocks the coronary arteries. And so, even though less blood makes it to the heart tissue, there's still blood. Heart attacks happen when there's a sudden, complete blockage or occlusion of a coronary artery. So let's see how that can happen. Since these plaques sit right in the lumen of the blood vessel, they're constantly being stressed by mechanical forces from blood flow. And interestingly, it's often the smaller plaques with softer caps, rather than the larger ones with harder caps that are especially prone to break or get ripped off. Once that happens, the inner cheesy filling, which remember is this mix of fat, cholesterol, proteins, calcium, and white blood cells, is thrombogenic. And this means that it tends to form clots very quickly. So platelets, or blood clotting components in the blood, flow by and get excited, and they adhere to this exposed cheesy material. In addition to piling up, the platelets also release chemicals that enhance the clotting process. Now this happens super fast. Think about how quickly a small cut stops bleeding. That's a very similar process. It happens in a matter of minutes, right? And now that coronary artery is fully occluded. So now let's change views a bit. If we take a slice of the heart like this side being posterior or the back, and this being anterior or the front, with the left and the right ventricles here, and then we have the three most commonly blocked arteries, the left anterior descending, or LAD, which supplies blood to the anterior wall and septum of the left ventricle, which accounts for about 40 to 50% of cases, the right coronary artery, or the RCA, which covers the posterior wall, septum, and papillary muscles of the left ventricle, accounts for about 30 to 40% of cases, and finally the left circumflex artery, or the LCX, which supplies the lateral wall of the left ventricle, about 15 to 20% of cases. Notice that the majority of these areas supply the left ventricle. Most heart attacks therefore involve the left ventricle, where the right ventricle and both atria, the upper chambers, aren't as often affected. Each of these areas is called the artery's zone of perfusion, and if we take a closer look at one of these zones, we'll see that basically you've got the endocardium, which is the smooth membrane on the inside of the heart, and then the myocardium, all the heart muscle, and then the epicardium, the outer surface of the heart, which is where the coronary arteries live. Let's say the LAD gets blocked. The area of perfusion is now at serious risk, and within about a minute, the muscle cells in this zone don't see enough oxygen and become ischemic, and the muscle layer's ability to contract is severely reduced. This initial stage is extremely sensitive, since the ischemic damage to cells in the perfusion zone is potentially reversible. After about 20 to 40 minutes, though, damage starts to become irreversible and the cells start to die, and this zone changes to a zone of necrosis, or dead tissue. Once lost, those cells can never return or regrow. That's why quickly identifying and treating an MI is super important. The first area affected is the inner third of the myocardium, since it's the farthest from the coronary artery and the last area to receive blood, and it's subject to higher pressures from the inside of the heart. If the blockage suddenly lyses or breaks down and blood flow returns, sometimes patients' damage will be limited to the inner third, and this would be called a subendocardial infarct. An ECG, or electrocardiogram, done at this point typically shows an ST segment depression, or in other words, it doesn't show ST segment elevation. So sometimes we call this an n-STEMI, which stands for non-ST elevation myocardial infarction. Other causes of this sort of subendocardial infarct would be severe atherosclerosis and hypotension, anything that ultimately leads to poor perfusion of the heart tissue. After about 3 to 6 hours, though, the zone of necrosis extends through the entire wall thickness, called the transmural infarct, which this time shows up as ST segment elevation on ECG, which is why they're sometimes called STEMIs, or ST elevation myocardial infarctions. So the difference between n-STEMIs and STEMIs is that n-STEMIs don't have ST segment elevation, and these are caused by partial infarct of the wall, whereas STEMIs have ST segment elevation and involve the whole wall thickness. Patients that have an MI will most commonly have severe and crushing chest pain or pressure that might radiate up to the left arm or jaw. They might have diaphoresis or sweating, nausea, fatigue, and dyspnea. All of these are either a direct result of an end organ, like the heart or the brain not getting enough perfusion, so think chest pain and dizziness, or from the sympathetic response from the body to help the heart work harder and preserve blood pressure, so think sweating and clammy skin. Many people also have referred pain, where the nerves in the heart are irritated, but that pain can be felt in the jaw, shoulder, arm, or back instead. In addition to an ECG, labs can be very useful in diagnosing an MI. When there's been irreversible damage to heart cells, their membranes become damaged and the proteins and enzymes inside escape and can enter the bloodstream. 3 key ones are troponin I, troponin T, and CKMB, which is a combination of creatine kinase enzymes M and B. Both troponin I and T levels can be elevated in the blood within 2 to 4 hours after infarction, and usually peak around 48 hours, but stay elevated for 7 to 10 days. CKMB starts to rise 2 to 4 hours after infarction, peaks around 24 hours, and returns to normal after 48 hours. Since CKMB returns to normal more quickly, it can be useful to diagnose reinfarction, a second infarction that happens after 48 hours, but before troponin levels go back to normal. A second heart attack happens following 10% of MIs. A major complication with MIs are arrhythmias, or abnormal heart rhythms, with the highest risk being immediately following an MI, since the damage or injury can disrupt how the cells conduct electrical signals. Kind of along the same lines, depending on how much contractile or muscle tissue is affected, patients' hearts might not be able to pump enough blood to the body, resulting in cardiogenic shock. In the days following an infarction, the tissue around the infarcted area becomes inflamed and is invaded by neutrophils, which can lead to pericarditis, inflammation of the pericardium. In the next couple weeks, macrophages invade the tissue, and the healing process begins with the formation of granulation tissue, which is new connective tissue that's yellow and soft. At this phase, the tissue is most at risk of myocardial rupture. After 2 weeks to several months, the cardiac tissue scarring process finishes, and the resulting tissue becomes grayish-white in color. Since the scar tissue doesn't help pump blood, over time the remaining heart muscle can grow or change shape to try and compensate for these lost cells and pump harder, but they ultimately continue to fail, which can lead to heart failure. Now, potentially life-saving treatment that can be done immediately following an MI is fibrinolytic therapy, which uses medications to break down fibrin in blood clots. An angioplasty might also be done, which is a minimally invasive endovascular procedure where a deflated balloon is inserted into the blockage and then inflated to help open up the artery. And finally, percutaneous coronary intervention might also be performed, where a tiny catheter is used to place a stent in the coronary artery to physically open up the blood vessel. Each of these focuses on re-establishing blood flow to the dying heart cells, since time is tissue. If early enough following blockage, some of these cells that haven't entered into the irreversible stage can be salvaged and saved, while the others will be destroyed and removed. This can improve both short-term and long-term function as well as prevent further damage and reduce the overall zone of necrosis. Now, an important complication of re-establishing perfusion, or reperfusion therapy, is reperfusion injury, where tissue is damaged by returning blood flow. And this is thought to happen because of a couple mechanisms. First, blood flowing back to the cells brings this influx of calcium. And since calcium leads to muscle contraction, the irreversibly damaged cells contract. And since they've been irreversibly damaged, they get stuck like that and can't relax. This shows up on histology as this characteristic contraction band necrosis. Also, though, blood brings along oxygen, right? Yeah, it does. But that oxygen, paradoxically, can actually lead to more cellular damage. The conditions in an ischemic heart seem to cause an increased conversion of the returning oxygen to reactive oxygen species, which can go on to damage more heart cells. In addition to reestablishing blood flow, though, there are a number of medications that might be given in the acute setting, including antiplatelet medications like aspirin, anticoagulants like heparin, nitrates, which relax the coronary arteries and help lower preload, beta blockers that slow down the heart rate and thereby cardiac demand, pain medication to help relieve discomfort, and statins which help improve a patient's lipid profile. Now, there are a ton of individual factors to consider when it comes to acute management of a myocardial infarction, and of course, many long-term issues to consider as well, the most important of which is to address the underlying risk factors, like an improved diet and quitting smoking. Alright, as a quick recap. Heart attack, also known as a myocardial infarction, or MI, is the death of heart muscle cells due to the lack of blood flow, most commonly caused by atherosclerosis of the coronary arteries. The most common symptoms of myocardial infarctions include crushing chest pain or pressure that might radiate up to the left arm or jaw, sweating, nausea, and dyspnea. Treatment of myocardial infarction includes reestablishing blood flow using medications, angioplasty, or percutaneous coronary intervention. But underlying risk factors should be addressed for long-term management. Thanks for watching. If you're interested in a deeper dive on this topic,
and see what we have there regarding coronary artery disease. We'll keep talking about that. Okay, their description then of angina. We covered in osmosis, chest pain, pressure, tightness may radiate to the jaw, arm, back. Remember, it can be precipitated by physical exertion. It can also happen at rest. Women are more likely to have non-activity related episodes like sensation of dyspnea, nausea, vomiting, abdominal pain, back pain. I can tell you my experience. I've also had weakness for women as something like they can't describe what's wrong. They just don't feel good and they're weak. It's worth checking into the idea of ischemia. Typically, but not always, we think that the angina can start as stable and then move to unstable, but some people don't have any symptoms until they have the big one. The book did a great job of sharing with us what the Prinzmetal angina is, or the variant angina. It begins during rest. There's no precipitating event. This is not something that you're going to fix in the cath lab. This is fixed typically by medication such as nitroglycerin. They can cause sudden cardiac death because if you just clamp off an artery that's supplying the major part of your heart and nothing relieves it, you could die. Acute coronary syndrome is coronary atherosclerosis, often progresses along the spectrum, then from stable to unstable. And we think we see the rupture of the atherosclerotic plaque, that fibrous cap ruptures, and that can create the immediate formation of a thrombus that will acutely, totally obstruct, precipitating cardiac tissue hypoxia and then symptoms of ischemia. You can have the n-STEMI with intermittent chronic tissue damage. In contrast, the complete obstruction of the coronary vessel may produce an n-STEMI or may rapidly destroy a greater volume of cardiac tissue, resulting in myocardial nephrosis and the full thickness, and that's what this STEMI is. Your book brings us, this is figure 10.3. This is the manifestation of an n-STEMI. During the n-STEMI, the ischemic region is typically in the subendocardium, and you have cell dysfunction from ischemia or poor blood flow, which results in the loss of ionic gradients. You get extracellular potassium accumulation, and you lose the membrane potential, and you start to see the EKG changes between the ischemic region and the normal tissue. And that change alters our electrical dipoles across the heart, and that's then reflected by lowered measured potential of the ST segment relative to the rest of the EKG, and that gives us ST depression. Fancy way to say that. During a STEMI, looking at this, it's important to understand that we're usually dealing with a full thickness or a transmural issue. A STEMI produces the lesion through the endocardium. It's irreversible damage, and it raises the measured potential during the ST portion relative to the remainder of the ECG. And so we're going to get ST elevation, as you can see there. The interesting thing is that the extent to which you have damage versus the extent of coronary atherosclerosis is not always correlated, meaning that the extent to which your coronary artery is narrowed is not indicative of the amount of myocardial ischemia. And so many women, for example, have severely narrowed coronary arteries on coronary angiography, but other women with severe myocardial injury may have very little to no signs of lumen narrowing. So we have started to consider microvascular disease, especially when it comes to women. And this idea is that the microvascular dysfunction in both men and women, but specifically more so in women, have angina and even myocardial infarction without the signs of disease in the large coronary arteries. So the amount of resistance and mechanism of flow regulation varies along the segments of the coronary microvasculature. So what they're also saying, though, is that what we're talking about then, I want you to understand the coronary microvascular dysfunction is that the coronary arteries travel along the surface of the epicardium, giving off branches that go to the 3 different depths before they branch into the smaller arteries, arterioles, and capillaries. Each segment of the vessel is regulated by different mechanisms, which is important to understand because the large epicardial arteries are about less than 10% of the vascular resistance. The smaller arteries are about 20%, and the large arterioles about 50% of the resistance that we have within our vessels. And this is important to understand. So, coronary microvascular dysfunction is the idea to describe vascular compromise that results in myocardial ischemia, but it's in the absence of the significant lesion within a large coronary artery. So factors such as abnormal vascular smooth muscle cell spasticity or reactivity or altered endothelial function can account for compromised blood flow arising from the microvascular dysfunction in the presence of coronary arteries that appear normal. A lot of words for saying that it's arteries that are very small that are having other issues or dysfunctions within the vascular smooth muscle. They're having dysfunctions within the endothelial tissue themselves. And so you're getting this death of small areas or damage to small areas of the myocardium. And it's not because you have a large ruptured atherosclerotic plaque. And so this is very challenging because how do you treat this? What are we going to do for that? So it's kind of this microvascular coronary artery disease or coronary microvascular dysfunction. So this is something you are going to see in practice. Myocardial ischemia and infarction can occur, of course, then we're saying without this atherosclerotic plaque. Okay, so we call it type 1, type 1 and type 2 type of microvascular dysfunction. This is where we talk about the idea then of demand ischemia, right? So that you have stress and strain on the heart, and it's at this microvascular level that we're seeing some gentle bumps, if you will, in troponins. So it's not because we have the death of a large area because of a blocked artery, so much as maybe it's demand, spasm, other things like that, the vascular smooth wall, the endothelial damage from sepsis, all these different things that we can get what we call this demand ischemia, which is the microvascular in origin. So it's really what's happening at the microcirculation between the endocardium and the artery. This is talking about the incidence and consequences of ischemic heart disease in women. Remember that we're thinking they have more microvascular disease and symptoms. So they may have microvascular disease before they have the macrovascular disease. If you do a coronary angiograph, it may not accurately reflect the risk because it doesn't catch the the microvascular disease. So we have to pay attention to this past our traditional risk factors. We have to be more aware of autoimmune diseases and chronic inflammation and some of those things that may contribute to the microvascular disease. We know that relative protection of estrogen is then lost after menopause, which is why older women, postmenopausal women, are at a higher incidence of heart disease. And again, this is something that we have to be aware of, that women don't always present the same either. That is the end of the slides for the part 2 of the lecture. But what I want to do is go back to osmosis and include some extra content, some extra video time anyway, to kind of bring in chapter 9 into chapter 10, because the cardiac and vascular have so many shared components, bringing back in some of the idea of arterial ischemia. So we're going to watch this video here.
Hypoxia, or lack of oxygen in cells and tissue, can happen in a number of ways, and ischemia is one of them. Isco means restraint or suppression, and emia refers to the blood. So ischemia must mean some kind of suppression or reduction of blood flow to an organ or tissue. And blood carries oxygen, right? So when there's a reduction in blood flow to cells, that also means there's a reduction of oxygen to those cells, and this is due to the lowered blood flow in the blood vessels. This lowered flow could be from something blocking the blood from the inside, or it could be something compressing the blood vessel from the outside. An example of something blocking the vessel from the inside is a thrombus, also known as a blood clot. These are solid clumps of platelets and fibrin that obstruct blood flow. Ischemia resulting from something outside the blood vessel is traumatic injury, which can cause inflammation and swelling that physically applies external pressure to the blood vessel, compresses it, and restricts blood flow. Alright, so let's say that this is your artery, and it's like the one-way highway leading all these red blood cells into the city, which is like a major organ in the middle here. So maybe this is Organopolis. These red blood cells are super pumped for their day, where they can drive around the capillaries, like the smaller city streets, and supply the city with fresh oxygen and pick up waste. And this Organopolis is made up of thousands of cells, like homes, that use up the oxygen and create waste that needs to be picked up. The deoxygenated blood cells drain out through different small streets, which are the veins, and go back towards the heart. So one way this organ city could become ischemic is if there's some obstruction to arterial flow into the tissue. Now only a few red blood cells can get in at a time. You might imagine that Organopolis sees a lot less blood and a lot less oxygen, and becomes ischemic. A super important and well-known example of this arterial ischemia is atherosclerosis, where plaque builds up in the arteries going to your heart tissue, which blocks arterial flow, reduces the amount of blood and oxygen that makes it to your heart tissue, and causes ischemic heart disease. Since you can have a blockage of red blood cells coming in, you can also have a blockage of red blood cells going out, leading to a decrease in blood drainage on the venous side. So in this case, you've got a major obstruction in the venous highway leaving the city. So say that these are like the veins draining blood out of Organopolis. All these workers are getting into Organopolis, but they can't leave because there's this blockage heading out, and traffic gets majorly backed up, causing flow to slow down throughout the whole city. This again leads to less oxygen to the tissues and ischemia. Thinking about an organ, it might get so congested that pressure can rise, causing fluid to get forced out of the blood vessels and into the tissues, generating edema. This whole example is very similar to Budd-Chiari syndrome, where the hepatic veins that drain blood out of the liver are blocked by a thrombosis, or a clot. And now blood can't flow through the liver, and the liver tissue becomes ischemic and can lead to liver edema and hepatomegaly, or enlargement of the liver. If the oxygen supply is low enough or long enough, it can cause cell death, and if enough cells die in a region of tissue, we would call that tissue necrosis and infarction. In some cases, there are areas of tissue that are getting close to infarction as cells begin to die off, but they're still able to get saved if they receive blood. This high-risk area that's teetering on the brink of death is called the ischemic penumbra. In some cases, there are two arteries serving a single area of tissue, and this goes against how we often think about tissue as being served by a single capillary bed from a single artery. But when you think about it in 3 dimensions, there can be a lot of overlap, right? If there are these secondary or collateral arteries going to the area, then there might be enough blood flow to keep the penumbra alive for a while. Over the course of weeks to months, these secondary arteries can even grow in size to bring more blood to that area, a bit like disaster relief. This process is called collateralization. So if blood flow to an organ is blocked all of a sudden, a super important concept to keep in mind is called time to reperfusion. This refers to the importance of reestablishing perfusion to the affected organ before the cells die and the ischemia becomes irreversible. Remember that perfusion and blood flow are slightly different. Blood flow is the volume of blood flowing per unit time, like liters per minute. Perfusion is like a measurement of how much blood is flowing to a chunk of tissue per time. So it might be given in liters per minute per gram of tissue. So as an example, if you compare the total blood flow to the kidneys with the total blood flow to the liver, it'd be higher to the liver because the liver is a lot larger. But if you took a 10-gram cube of liver tissue and compared it to a 10-gram cube of kidney tissue, the kidney actually has higher perfusion, since it has more blood vessels packed into its cube. Now, back to reperfusion. If perfusion to the area is reestablished quickly enough, then it's possible that the ischemia is reversible because the cells were dying, but they're not dead. If too much time has passed and the cells have actually died, then the ischemia is irreversible since you can't bring back dead cells. One example of irreversible ischemic damage is something like a heart attack or a myocardial infarction, where an artery supplying a specific part of the heart with blood becomes blocked, causing death of that part. Depending on the area that's affected, this could cause serious heart dysfunction, Like if enough of the heart's ventricle was damaged, it might not be able to pump blood as well anymore.
So let's stretch this a little further and make sure we have a really good understanding of the EKG, infarct, and ischemia.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind, and one of them includes figuring out if part of the heart is suffering from ischemia or has had an infarction. The term ischemia means that blood flow to a tissue has decreased, which results in hypoxia, or insufficient oxygen to that tissue, whereas infarction goes one step further and means that blood flow has been completely cut off, and this results in necrosis, or cellular death. That typically happens if blood flow has been cut off for about 20 minutes. In the heart, ischemia and infarction can be transmural, affecting the entire thickness of the myocardium, but it can also be subendocardial, affecting just the innermost part of the myocardium, the part just beneath the endocardium. Out of all four chambers of the heart, the ECG is most sensitive to transmural or subendocardial ischemia or infarction in the left ventricle, because that's the chamber with the thickest walls and therefore has the most cardiac tissue. Alright, so let's start with subendocardial ischemia, which might happen when there's an incomplete blockage, let's say about 70%, in the coronary artery. In that situation, at rest, there's usually enough blood flowing to meet the demand of the myocardium. But during exercise, there's not enough to meet the myocardium's increased demand. In that situation, the subendocardial tissue gets ischemic, because it's the last bit of tissue to get blood from the tiny branches of the coronary arteries as they make their way through the ventricular wall from outside to inside. This condition is called stable angina, because there's ischemia which causes chest pain with exercise, and then it disappears with rest. And there's also unstable angina, which can happen with incomplete blockage of a coronary artery, but in this case, chest pain appears at rest. When there's subendocardial ischemia in a region, it causes ST depressions in the corresponding lead on the ECG. An ST depression is when the J point, which is where the QRS complex meets the ST segment, goes down by at least 0.5 millimeters, or 1/2 of a small box. The ST depression can be upward sloping, downward sloping, or horizontal. In subendocardial ischemia, ST depressions are usually widespread, often affecting leads 1, 2, and V4 through V6. With such widespread involvement, it's tough to determine which coronary artery caused the ST depression. As a little side note, if the ST segment is depressed and curved, it might actually be due to digitalis effect, which is when the patient takes the medication digoxin, rather than being due to subendocardial ischemia. On the other hand, subendocardial infarction happens if the coronary artery remains blocked for around 20 minutes, and the subendocardial cells begin to die, resulting in necrosis. And with necrosis, the subendocardial cells leak cardiac enzymes, like troponins and CKMB, into the blood. With a subendocardial infarction, there's no ST elevation on the ECG, so this is called a non-ST elevation myocardial infarction, or an n-STEMI for short. Instead, the ECG can show ST depression and T-wave inversion. On ECG, both unstable angina and n-STEMIs might show ST depression as well as T-wave inversions. The difference is that with n-STEMIs, cardiac enzyme levels in the blood are elevated, whereas with unstable angina, the damage resolves in a short time window, so there's no cardiomyocyte death, and therefore no elevated cardiac enzymes. With an n-STEMI, the ST depression looks similar to the one in subendocardial ischemia, and the T-wave inversions are usually symmetric and at least 1 millimeter deep, or one little box, and are most noticeable in the chest leads, but can also appear in the limb leads. These also have to happen in at least 2 contiguous leads, meaning adjacent leads. For example, lead V2 and V3 are contiguous, but leads V3 and V5 are not contiguous. There can also be a dominant R wave, meaning that the R wave has a higher amplitude than the S wave. Now, it actually turns out that a little bit of T-wave inversion can be normal, especially in leads 3, AVR, and V1. But any sign of T-wave inversion in leads V2 through V6 is considered abnormal. Alright, so next there's transmural ischemia. And this can happen when a coronary artery is narrowed from an atherosclerotic plaque buildup over time. Now, there are 2 parts to this plaque, a hard fibrous cap and a soft cheese-like interior. As the blood flows past the plaque, the fibrous cap can sometimes rip, and that cheesy interior is exposed and considered thrombogenic, meaning that blood clots form on it really quickly, and that can quickly plug up blood flow. Transmural ischemia can happen secondary to vasospastic angina, also called Prinzmetal angina, which is when a coronary blood vessel spasms and narrows, cutting off blood flow to that cardiac region. Vasospastic angina happens independent of traditional risk factors, like atherosclerosis, and can be triggered by tobacco, alcohol, or cocaine use. Finally, we have transmural infarction, which happens when a coronary artery becomes completely blocked for greater than about 20 minutes, and this causes transmural necrosis. Within minutes, a transmural infarction leads to ECG changes. The most common would be a T-wave inversion, but there might also be hyperacute T-waves, which are large asymmetric T-waves that appear in at least 2 contiguous leads. The classic sign of transmural infarction is ST elevation, And when that happens, it's called an ST elevation myocardial infarction, or STEMI. On ECG, the ST elevation at the J point must be over 1 millimeter in any two contiguous leads except V2 or V3, where it has to be over 2 millimeters. On an ECG, both a STEMI and vasospastic angina can cause ST elevations, but with vasospastic angina, the elevation is transient. Another key difference is that with a STEMI, the ischemia is so severe that damaged heart cells die, resulting in myocardial necrosis, and leak out certain enzymes like troponin and CKMB. ST elevation, though, can also be caused by other conditions, like left ventricular hypertrophy and pericarditis. As an example, a 20-year-old physically fit person with a viral illness that gradually develops chest pain and is found to have ST elevation on ECG is actually more likely to have pericarditis than an ST elevation myocardial infarction. Besides ST elevation and T-wave inversions, a transmural infarction can also cause pathologic Q waves to appear on the ECG. Normally, depolarization in the ventricle spreads from the endocardium to the epicardium, and most of that ends up pointing toward the positive electrode, which means a positive deflection. With infarcted tissue, though, it doesn't conduct electricity, which means that the electrode essentially sees through the infarcted tissue, sort of like as if it was just a hole. And it sees through the hole to the other ventricular wall. And since those are mostly moving away from the positive electrode, you end up with this big, negative pathologic Q wave. So pathologic Q waves are those that are longer than 0.04 seconds, or 1 small box, and over 2 millimeters, or 2 small boxes deep. Now, the location of the transmural infarction can be identified based on the lead that has pathologic Q waves. Septal wall infarctions show changes in leads V1 and V2, whereas anterior wall infarctions show changes in leads V3 and V4. Anterolateral wall infarctions show up in leads V3 through V6, as well as 1 in AVL. Small subendocardial infarctions don't actually cause pathologic Q waves, because some of the affected wall still conducts electricity. Also, the AVR lead is oriented in a way that normally produces Q waves, so it's actually not a reliable lead to look for pathologic Q waves. Finally, pathologic Q waves can also result from things other than transmural infarction, like a left bundle branch block and Wolff-Parkinson-White syndrome. After a transmural myocardial infarction, the ECG gradually starts to look more normal. During the first 2 days, there might be T-wave inversion, ST segment elevation, and pathologic Q waves. But around day 3, the ST segment's often back at baseline. After a few weeks or months, the T-wave inversion might start to improve as well. But pathologic Q waves can linger for a lot longer. And this is why it's always important to compare ECGs to previous ones to look for new changes. Alright, as a quick recap. Subendocardial ischemia can reflect stable or unstable angina. Subendocardial infarction causes an NSTEMI. Stable angina, unstable angina, and NSTEMIs are associated with ST depressions and T-wave inversions on ECG. But the difference is that with NSTEMIs, there are elevated cardiac enzymes like CKMB and troponins in the blood. Transmural ischemia can reflect vasospastic angina, whereas transmural infarction leads to a STEMI, and this causes ST elevation on an ECG. The key difference is that with vasospastic angina, the ST elevation is transient, and with a STEMI, there are elevated cardiac enzymes in the blood. Additionally, with a STEMI, the ECG can show T-wave inversions and hyperacute T waves, as well as pathologic Q waves.
All right, you guys hung in there for another hour of this lecture. I'm going to end it here. So this is going to be the end of part 2, video 2. So then we'll meet you in part 3.